Good afternoon, esteemed guests. We, the Oval Fertility family, warmly welcome you on this Sunday afternoon to an enriching session of knowledge sharing, deliberation, and rejuvenating our professional relationships. I am Dr. Kirtana, consultant ART specialist at Oval Advanced Fertility Care.
And I'm Anu. I work at the Oval Fertility Care. We are truly privileged to be hosting you today. Our program for this afternoon is as follows. We will begin with an inaugural ceremony, followed by the reveal of the Oval brand. This will be succeeded by 4 insightful lectures covering a wide range of topics. Before we move on to dinner, we host a thought-inciting panel discussing exploring the gray zones in IVF. We now invite our panel members, Veena ma'am, our co-founder and director, Dr. Brian, our co-founder, Dr. Sandeep, our chief medical director, Dr. Sanket, our embryologist, and Dr. Kirtana onto the dais. Mr. Chandrasekhar is the CEO of Oval Advanced Fertility Care and brings with him tremendous experience in this highly specialized field of medicine. Prior to this association with us, he served as a Chief Operating Officer of Nova and 39, among many other prestigious roles. We now hand over the dais to Mr. Chandrasekhar.
Good evening to everyone, and a very, very warm welcome to this launch ceremony and the CME of Oval Advanced Fertility. I've been given the honor of moderating this first panel. I'll try and do my best. We're going to ask a series of questions to the esteemed members here, and we hope that we get the right answers before we unveil the logo. My first question is to my co-founder and director, Mrs. Veena Reddy. Ma'am, what was the core mission that inspired you to create Oval Fertility? And second part of the question is, how does it differentiate itself in the competitive landscape of Hyderabad's reproductive medicine? Over to you.
When my in-laws Sanjay and Pinky came up with the idea of Oval, their vision was very clear. They wanted to redefine fertility care in India. And the idea behind Oval was very simple. We knew that fertility care should be just as personal and compassionate as it is clinically advanced. Every patient that goes through this journey, it's a deeply emotional journey. And what do we look for? We just want to feel safe, supported, and seen. And I can vouch for every patient out there because I went through this journey myself. What differentiates Oval? We are a combination of world-class technology. We have clinically amazing doctors. And, we are highly personalized in private patient experience. Put all of them together, and that's Oval. And I keep telling everyone out there and whoever I meet, you really have to see us, come see our space to believe what we've built. We're truly unique, and I don't think there's anyone else out there in creating what we've created in the industry currently.
Thank you so much for that. Wonderful to hear your words. It's the compassion behind the work that stands out. Thank you so much for your kind words. My next question goes in two parts. One is to our medical director, Dr. Sandeep, and our head of embryology, Dr. Sanket. You may choose to pick up whichever you would like to answer. The question is to you is, what is the philosophy behind the technology and laboratory infrastructure choices made for this facility, and how do these contribute to patient outcomes?
Sanket is younger. I think I'll let him take the first shot.
So
Dr. Sanket.
The philosophy is very simple. Every decision in terms of equipment or technology is very precisely done. Just everything has to correlate with the patient outcomes. That's how it's been chosen. It could be time-lapse incubator or electronic waiting system, because that gives us every detail. So that will not allow us to go mismatch or error rates. Plus also we have something called as lab care and lab health that also has, which even sitting here also can track what is the percentage of gas inside the incubator, what is the percentage of humidity inside the lab. So all these things are very carefully chosen just for one reason. just to increase the success rates and give the pregnancy rates for the families.
And can you define success rates?
Success rate for us in terms of embryology is all from fertilization to cleavage to blastocyst formation, survival rate, blastocyst biopsy rate. So for us, a lot of there, but ultimately everything boils down to one thing, that is pregnancy.
So
I would
this
take
is
it a little
slightly,
further.
yeah, sure.
I mean, me being a clinician, I'm not only happy with pregnancy. I want, at the end of the day, a healthy mother and a healthy child
Precisely.
being born. Continuing with the question you asked, it also involves a lot of QA/QC, rigorous checks and balances at every step. And also, we have not only made the clinical part transparent, we are trying to make embryology also transparent, involving the embryologist along with the patient for decision making, explaining every step in embryology as to how it will improve or whether it is really necessary, rather than giving a size fits all for all the patients. We are trying to actually personalize even embryology, not only clinical side.
Happy to hear that, Dr. Sandeep. Thank you so much, Dr. Sanket, for that. When I said define success rate, is that, of course, we're all from the same industry. This is slightly out of sync, but almost all IVF clinics look at success rate as a beta HCG positive.
Beta HCG positive, but
What is it different in Oval?
LBR. We go for LBR. That's how we planned. So track every pregnancy till the live birth happens. So that's how the vision and mission of Oval has been.
Excellent. Thank you so much. Dr. Brian, welcome to India once again and welcome to Oval. This next question is to you. And we are increasing seeing the influence of AI in technology across the world, especially in the IVF landscape. How is Oval Fertility integrating these advancements, specifically in areas like automated embryo grading or semen analysis, to improve precisions?
So first, thank you for having me here today, and thank you for all being here today. It's impossible to talk about healthcare and not talk about AI. AI is pervasive throughout everything that we do today. We know our patients are using AI to ask their doctors the right questions. We know that doctors are using AI to better analyze patient records. And most importantly now, AI is being introduced into the laboratory. In my lecture later this afternoon, I'll explain the different methodologies that are used for AI. That's the hook to keep you all here. But more importantly is to understand that Oval is set up to integrate AI at the earliest steps. Our laboratory today is one of the only laboratories in India using an advanced time-lapse integrated system that has AI built into it. We're also set up to use AI in our medical records if necessary. And we have the tools and assets and resources to allow AI to be deployed to take care of patients in a more holistic and meaningful manner.
Thank you so much, Dr. Brian. And I know you not just believe but also practice a lot of AI in your clinic. I've seen that personally in New York. Thank you so much for that. I'm looking forward to your speech later this evening on AI and IVF. Dr. Sandeep, this one is next for you in terms of transparency and trust. Success rates, we just discussed a bit about it, are often a topic of confusion for patients. How will Oval Fertility approach the communication of outcomes to ensure that the patients are empowered, informed, and they have realistic expectations?
Okay, I think one of the key factors or key pillars of Oval is going to be transparency at every point in time. Transparency with respect to prices, transparency with respect to success rate, and not only that, at every point in the journey, the patient will be free to communicate to us with the presence of an app. So we are going to give the patient an app through which each and every question can be asked without actually going through any other platforms which can be hacked. So we have a very private sort of a conversation despite it being through the phone. And also, as I said, if one of, I taken Dr. Ruma around, so we have a very transparent lab with a communication through the walls of the lab to see what's happening there. So that at every point, why we do a certain procedure, what is the science behind it, what is the success rate behind it, is it really required for you, everything at every point and step will be explained very clearly to the patient. And we empower the patient to make a decision with all the knowledge that we impart to them.
A little bit about this app, it sounded interesting. How do you expect that to, we are giving the patient the app?
Sorry, I couldn't.
The app, the Oval app you talked about, is sounding very interesting. So it's communication between the clinic and the...
So everything the patient needs will be serviced via the app, be it a blood test, be it a consultation, be it ordering medicines to their home, or even booking an appointment with a doctor, or if there's a query, everything can be done via the app.
Excellent. Thank you so much, Dr. Sandeep, once again. Dr. Kirtana, this one is for you. Standardization versus personalization. In a multi-centric model, how do you ensure that clinic protocols remain standardized to maintain high success rate while still providing the personalized care that every patient deserves?
Standardization, basically it ensures that there is consistency that is being maintained in, say, like lab QC benchmarks, any monitoring thresholds, safety cutoffs. So standardization is required for consistency in all of this. But within that zone, we also have the clinician is empowered to tailor the treatment stimulation, the timing, the transfer strategy with respect to the patient's history. So in other words, if standardization is what it makes us any treatment consistently safe, whereas personalization makes it consistently successful.
Excellent. Excellent. Thank you so much. Now we come almost close to the end of this panel. I have 3 rapid fire questions, right? And this is to all of you. One by one, if you could answer this. It's a rapid fire question, so please be ready. If you have to describe Oval Fertility experience in one word, just one word, what would it be? Dr. Sandeep?
I doubt if you can fit it in one word.
That's 5 words already.
I think it would be wholesome.
Sorry?
Wholesome.
Wholesome. Okay. Dr. Brian?
I'm going to take Veena's word,
I know you're going to take that.
and it's a sanctuary.
Sanctuary. Veena, ma'am?
Took my word. A safe space.
Safe space. Okay.
I would say trust.
Trust. Dr. Sanket?
Technology.
Technology. Okay. The next rapid fire. What is the single most important piece of advice you would give to a couple walking through your doors for their first consultation?
Again, just one word?
Just one word. Advice.
Advice. Okay. I mean, it's generally not written in many books, but I would ask them to get their BMI correct.
The BMI correct.
I think patients need to know that they're not alone.
I think I would say, we got you. We got them. We'll take care of them. Yeah.
Thank you.
Again, I would say trust the process, not the timeline.
Keep trusting us.
Keep trusting us. Okay. The last one. What is the one technology? I know what you will answer. What is the one technology or trend in reproductive medicine that you are most excited to see mature in the next 12 months? I know Dr. Brian's answer. I know Dr. Sanket's answer. But yeah, let's hear it from them. Start from Dr. Sandeep.
I'll say AI.
AI? Okay. What goes to?
The most exciting technology is actually the medicine and the pharmaceuticals. I don't think people think of medicine as a technology today, but there's a really cool drug that's here, and I'm super excited to deploy it
Excellent.
at Oval.
Yeah, absolutely true. Yeah, it's evolved a lot. You know, ma'am?
I think I would go with medicine as well.
Medicine as well.
AI-driven personalized treatment.
AI-driven personalized treatment.
Same. Already we have AI in time lapse in Oval.
Excellent.
I want better AI to be there in the part of incubator.
Thank you so much. With that, we come to the end of the panel discussion. Thank you, wonderful guests, for all the answers that you've given, especially the rapid fire. Thank you so much.
Thank you, Chandrasekhar sir, and I thank all our esteemed panelists for illuminating the values and the ethos we aspire to uphold. We request our panelists to take their seat in the front row now. Let us take this moment to reaffirm our collective commitment to scientific, transparent, and ethical practice. Moving on, I request the gracious presence of Mrs. Pinky Reddy Garu, Dr. Shashikala, and Dr. Savita for lighting the lamp. I request Pinky Reddy Garu to stay on stage for the logo reveal.
Hope comes to life, and the future comes closer. Guided by science, backed by trust. A private sanctuary with a new path to parenthood that's personal and reassuring. Oval. Conceive the future.
Thank you so much, ma'am. Now, moving on, we enter the challenging world of IVF. Moving forward, we now transition into our core medical discussion and we begin with our strong opening speaker.
In IVF circles, it is often said if you do not know who Dr. Neena Malhotra is, you're not doing IVF.
It is my privilege to introduce Dr. Neena Malhotra, Professor and Head of Department at All India Institute of Medical Sciences, New Delhi, and current President of the Indian Fertility Society.
Her expertise spans reproductive surgery, endometriosis, and oncofertility, underpinned by significant contributions to ICMR-funded research in PMOS, ovarian tissue cryopreservation, and reproductive medicine. She is the recipient of numerous honors, including the Sir Malcolm Black Fellowship from the RCOG London, multiple Foxy Awards for excellence in research, a testament to a truly illustrious career. We are deeply honored to have her with us today. When to refer a patient to IVF is always a dilemma. Are we sending them too early or too late? Dr. Neena will be enlightening us on window of opportunity, optimizing the general gynecology practice for fertility.
So, a very good afternoon or a good evening to one and all here. At the outset, let me thank the team Oval for having me here, and of course, my colleague of yesteryears and my dear friend Dr. Sandeep to have invited me to this topic. And I think when there's an invite from Sandeep, I can never say no, not just because he's a good and dear friend, but when he invites you, I think there's a hidden message. His topics are going to be out of the box and definitely challenging. And I thought very times that what am I speaking in the 30 minutes to talk about opportunities that happen. And so I think the first bit of my talk would be a little overview what fertility practices are across the globe, how fertility trends have changed, and where are we on crossroads today in India. So not a very happy note, the global fertility rate world over are declining, and we know that. And of course, we look at trends, including India, we are producing lesser and less babies. And that's what the global fertility rate says so. If you look at the global stats clearly, today, India has a total fertility rate 2.3 in some states like Sikkim, well below 2, which is not the normal standards. So are we really saying the world is shrinking? Not really. Or do we say that there is a rising infertility? I think there is a bit of caveat here because declining fertility or delaying fertility is the big question today's day and age. I know there are reasons and reasons beyond what we can understand because women are finding making babies or procreation on the back seat because of rising, trends of urbanization, the lifestyles, and of course, women want to put their careers on prioritize them as against creating babies. If we look at stats across Europe, there is a trend to delay bearing the first child across European nation, and we can see that. But what's far more impressive, do we have any data from India? Really not. And what we have from the Asia Pacific, clearly they say that women are delaying their first childbirth for obvious reasons across the globe. A nice, analysis which came in BMJ long back, which said, are we overusing IVF, i.e. means of using artificial means or going to the lab to create babies or create life? And that was really a nice kind of analysis which came, which was an eye-opener. And then subsequently, a nice article which came in the Human Reproduction almost 6 years back, which said that there is an increase in the total number of ART cycles that we are doing globally. So if we look at statistics which clearly says, there are 1 in 6 couples which suffer infertility, over 12 million babies born world over from IVF. And of course, in India, where we don't have a registry, we kind of sort of assume these are the numbers. for the indications that we know, and I'm sure all of the general gynecologists would understand. But we should not forget that today we are expanding on horizon of fertility preservation, i.e., we're using these as a means to kind of defer and make our choices to produce or reproduce. I think in today's day and age, I think what the new generations are looking at IVF probably as a switch between making sex or having babies, or I would just say the so-called economists call a Veblen good effect, wherein the pricier the equipment, or pricier the commodity, the more is in demand. Are we making IVF a Veblen good? And that's what is something to debate. I thought I would just share you some of the insights of our paper that we published in 2024, a hard work that we did over 5 years, beginning from 2018, of what are the variations of ovarian reserves across India. And we did it across close to 6,000 women who are fertile and infertile. And we basically wanted to know at what cutoff do our Indian women begin to decline the fertility? Because the concern is I can put making babies on the back burner because career is priority. But there's something far more important to tell. How far can they hold that? And therefore, when we looked at the two pertinent markers, AMH and antral follicle count, as we call as ovarian reserve markers with age in both fertile and infertile, they showed trends which are not similar to what we saw in Caucasians or the Europeans. And of course, there was a decline per year. And what was more interesting on these GAMLAS modeling, we found that they did show a non-linear decline in the fertile, but a very linear decline in the infertile. And when we took out the so-called formulas that we used to define at what cutoff do women start decreasing, and we used standards of the antral follicle count to people who understand this part of the science, we found that 31.7 was what an average Indian was showing a decline when she was having babies, and 35 years, almost 34.4 at the ages of the ones who were infertile. And similar trends, i.e. to say that women in India are beginning to lose or decline the fertility much earlier than what their Europeans or Spanish or American counterparts. And I think we were similar to what we saw from trends from the Singapore or the Chinese women, i.e. to say perhaps the Southeast Asians have something in common. What about men? And I think these are two brilliant papers coming from the same group in the same journal, published in 2017 and then in 2023, to tell us it's not just the women who are losing their fertility, it's the men who are also showing a decline in the trends of the semen analysis. And this was a beautiful, meta-analysis and meta-regression which came on the temporal trends in the 20th and the 21st century. Well, if you'd like to read it, you can go, and I won't really take you deep into it. But something which came recently was not just from men who were infertile and getting the semen analyzed. Let's look at fertile men who were actually semen donors. So as to say, even the trends were not very impressive. And we see that there is not just a decline in the numbers, but the total motile sperms are also declining. And these were trends which were seen in 2019 to 2022. So then comes a thought, is this decline in fertility or declining reserve both for men and women, is it genetic because we are born with this kind of a genetic makeup, or it's perhaps environmental, our lifestyles? And I think we'd clearly say there's something to say in the environment, what we live, what we eat, what we breathe. And there comes the understanding that we are definitely not breathing, eating right, not just when we are born, but well before we are born, and probably with what my grandmom ate and what my mother ate. And that's what we call the epigenetics of a lot of disorders, including cancer. If you have a look around, I don't think we can say that we are depriving ourselves of any of these products. We are all sort of embracing them and sort of living with them. And we say we can't deny that we can't live without them. So let's see, what does environment do on men? Yes, it decreases their sperm counts. And there are a whole lot of, kind of biochemical agents that have been looked out. And I don't want to take you into details. But a lot of evidence that are coming against what we are breathing, the air conditioning, the petrol, and of course the aviation fuels that we sort of breathe in and out. And then the women is not far behind when it comes to these kind of environment pollutants. It's again the same story, affecting not just her oocyte quantity, but also aging and in pregnancy when she bears a child. So therefore to say, then we come on that we do understand that fertility is on the brink, But then what does a general OBGYN have to do and how does she take this? Because we understand that as fertility specialists, we do get patients who are referred to us and they will come. But I think before they reach us, there's a very important role of our colleagues who see them much before us, well before when they are younger. And I think that's what I would say. The window opportunity for the OBGYN. Is it for whom? When do they see? And what and how do they handle them? And I think if one is fond of reading committee opinions from standard guidelines like the American College of Obs and Gynae, I think this comes very beautifully. The obstetrician gynecologist is often the first healthcare provider a woman will seek for evaluation or concerns about fertility. And I think we should not just say when she's saying, I want a baby, it's going to be well before she needs a baby. When she comes for a preconception consults, I think it could be before they're getting married, what we say when they come to have a contraception visit, when they're getting married. I think that's what's important to tell when people are getting married at the age of 36 and want to take a contraception for another 2-3 years. I think that's where lies the importance when we have our own data coming on the normograms that we have drawn from 6,000 women. Of course, when they're coming to us for any gynecological evaluation, including PCOS, endometriosis, for the annual gynae, and of course, when they suffer recurrent pregnancy loss, besides if they have STIs. And I think which we see as a general OBGYN or a gynecologist, I think what are the areas that we need to address? Is there a couple that's coming to me? I'm going to really ask to check whether a couple has a normal semen count or there's ejaculatory competence. Is the woman ovulating? I.e., does she have regular periods? And I think some tests. And of course, to know the pelvic anatomy is normal and not just anatomy, the coital functions are adequate. So simply to say, when we look at evaluating fertility, I think these are all the factors which as a general gynecologist or as a fertility specialist we look in, and there are reasons for us to understand these are the causes. But I'm sure when we do look at, are their structures normal? No, not really. I want to know, are they functioning normal? Because there may be something which looks normal but doesn't behave normal, and that's what is the very important role of a general gynecologist. So to put it simple, the ACOG, or the American College of Obs and Gynae, in 2019 gave us really crisp guidelines to say what you should evaluate. Of course, a detailed history and examination is paramount to any clinical practice. Even though the apps come or the AI come, the first consult and the touch is important. And I think there will be areas where we look at, for the woman, we look at the evaluation that we come across with after evaluating her, putting some of the tests like the ovarian reserve test. We do an endocrine evaluation. We look for the men, for their history, and of course, a detailed historical, evaluation, which gives me a lead, but then more than that, a simple semen analysis. And I think when I put it simply, I just don't want to see them in silos. I want to see them as a couple rather than just individuals. And then when we look at the committee opinion on the evaluation, we're looking at diminished reserves. And I know that there are data which show that Indian women are aging 6 years in advance to the Spanish counterparts, which again is a very brilliant paper in fertility sterility. And of course, we know we're going to have tests like the AMH or the basal FSH, plus many more, including the transvaginal ultrasound when we do their basic ovarian volumes or the antral follicle counts, to say that there is a place of testing them whether they ovulate, because this is something which we can check not just by the history, but simple hormone assays. And I think a very important role of a simple scan, which can get you so much beyond the anatomy, i.e. the physiology. But then I think in this assessment, I don't think we should be kind of lost or meandering by ordering so many tests simply to understand that she is ovulating, she has a good reserve, but beyond that, in a setup like ours, where we have subclinical hypothyroidism, also to evaluate for a TSH. And therefore, I think even if this comes from an American society, which says there's no need for routine TSH testing, I think in India, we still have room and still place to test women, because when they're planning their pregnancy, beginning a hypothyroid would be a challenge when she continues pregnancy. What about doing a scan? I think this is something which we do in and out. But are we understanding that just a simple scan can give me not just the anatomy or the sonoanatomy, a lot can come from the physiology, and that's what a general gynae has to understand, rather than wait for us to diagnose she has a thin lining or a thin endometrium, or the soil is not good. And therefore, when we do a structural assessment, we just look at the uterus, we look at the functionality. I'm just not looking at an organ which looks beautiful. I'm looking at the soil, which can be potential or has a potency to nidate or to have the nidation of a good embryo. An ovary, which is not just looking good, but functions well. and has a good ovulation, and of course, the tubes which function and do not have any pathology. So simply to say, that's when I would say a general gynae comes well before we can sort of take her further. But what about the man? I know semen analysis is the cornerstone to any evaluation when we see the couple. We know we've come too far from a semen analysis that we've been doing over the years. And with the sixth edition in place, we do know that the trends have changed. And if you look at from 1987 to 2020, we've also lowered the bar. We've kind of realized that the semen quality is not so good, moving from motility of 50 to 42, and then moving from the normal forms of 50 to 4%, because we know that even whatever criteria we follow, we are realizing that in today's day and age, getting a man with a good morphology is rather difficult. So this sixth edition is what I would again say is what a gynecologist should really go through. It's not we who should be telling them, because it's simple, yet very handy, yet gives us a lot of information, not just on the basic evaluation, but sometimes when we do those extended tests, which we need in certain situations, to some which we really do not need, and maybe just in the realms of science and research. So as to say that a general gynecologist is a very important person to us to evaluate and screen and refer these patients earlier if they find something is abnormal in any of these semen or microscopic parameters. Yes, we won't expect them to look into extended or advanced, keeping it in the preview of the fertility specialist, but something they should know that they should not be ordering outright. But then I think it's very important what we need to learn, but there's something we need to unlearn as well, i.e., am I overdoing test? Because what is the idea of helping this couple when they come to us is giving them a cost-effective analysis, a cost-effective assessment, which is not so time-consuming and is not harrowing for the couples. And I think some tests, which we should unlearn to do is offering laparoscopies when they're not indicated, i.e. to somebody who doesn't merit, if she doesn't have an endometriosis or something suggestive of tuberculosis, why do I scope her? To very advanced semen analysis, which I don't think is in the preview of a general gynae or for us as well, to some of the tests, including the postcoital test or tests which are not needed, including biopsies and prolactin assessments. And then when we know that we have unlearned some and we've learned what is the right way, I think there lies the role of the general gynae in hand-holding and guiding these couples, because there can be many things that can be done out with IUI or even an ART or the more intensive test or intensive procedures. And that is, look at how could she optimize the conception in a woman with just natural intercourse or natural time. And that is maybe improve what is subtle, like not just an overt, but also a subclinical hypothyroidism or hyperprolactinemia, which have been detected if she had some symptoms, and also maybe identify and treat anovulation for us before she reaches. And of course, some things which should not be routinely, because when you see the prescriptions that they reach us after 8 or 9 years of trying are full of all those cocktails which are perhaps not needed, maybe those steroids, the aspirins, and the empirical therapy of luteal phase support with progesterone, sans the industry which pushes you and drives you to write them. Of course, we do understand there's something maybe casual or causal, and I won't speak again something like vitamin D or good antioxidants, because they do certainly help to some and may not help the others. But then what is the way forward when we say they're trying to have a baby, and what can we do for this couple? Let's look at the women, and I think Sandeep rightly pointed out, are they fit? Are they of the good BMI? I think yesterday only we were in an eating joint meeting the Zenzis in a nice pub and bar, and I said, yes, Hyderabad is a way forward in an industry which will boom with IVF. The way women are smoking and they're taking to alcohol and they're increasing BMI, I think this is the place to be in. Nutrition optimization, of course. Are they sufficient in their vitamin D? Are they sufficiently corrected for anemia? The thyroid control, diabetes optimization. Again, a very important fact on the vaccination. Are they rubella immunized? Because when they come to us, we realize they're not. And that's something which even a general gynae can do and relieve us of the time lapse or the time that is wasted for this. And a very, very important aspect of sleep and stress management in today's day and age when their corporate jobs are so demanding. Who gets the privilege of early to bed and early to rise? I think that's not the norm of today, and that's not the norm of today's generation. But something we can at least talk to before they can sort of sort of realize that it's relevant and give them some kind of information through our data, through our statistics. What about the man? Yes, smoking, obesity, regular exercise, and I would just add here, I missed something called diabetes, because when we see semen, we realize there's abnormal semen is when we're going backwards to realize this man had diabetes, and this was not checked. It was the semen analysis which helped me correct and check the diabetes. And of course, manage a lot of habits, including eating, sleeping, and of course, the metabolic syndrome, which is there with rising obesity. So then lies the question, if she can manage, is she in a situation to keep managing them with herself for years, or maybe refer them early? But then there will be some couples and some women who would rather need an early referral, and who are they? Those who are beyond 35, and I would say who are beyond 33 and 34 in our setups, because that's when they're declining. Or when they're just not waiting for the 1 year or 2 year gap, because by definition, we've got to wait until 2 years till they have a baby. I think I can refer these women earlier. But I know this male factor, there is a severe male factor. There's a history which says there is a history of an undescended testes in the childhood, or some surgery which does not permit to kind of me to wait and watch. If there's a tubal disease, yes, certainly. When we have genital tuberculosis, I don't know about Hyderabad, but from Delhi and the public hospital that I work, we still do see a lot of women and couples suffering tuberculosis. And that's where we get our alarm bells ringing. To those who have low ovarian reserves, and I think we can get them from the history, not just by waiting for an AMH or an antral follicle count much earlier. To those who have recurrent IVF failures, I don't think I can just hop around. I need to refer them to centers which are centers of excellence, who know they're going to do the right job, to send them to centers which have the right technology and the right human resource. And of course, when they have severe endometriosis, I just can't wait and watch with the standard treatments. I know that today in my country, we are in crossroads. We are the most populous country. Yet, if you look at access, do we need so many IVF units? Certainly. And I will tell you this data, which is not very recent, but it comes from the worldwide disparity. If you look at the number of ART cycles that are done per million inhabitants, I think India, even though it was 6 years back, we're not really made a dent. As against Belgium, where it does close to 3,000 IVF cycles per a million inhabitants, we were doing just 79. Maybe we've just reached 200 or 150, but we are way behind. And of course, the affordability is a big issue in my country. So are we right today? But I think as a general OBGYN and as IVF specialists, we do understand, again, we are on crossroads with technology advancing, with all personalized care, personalized stimulation, predicting endometrial receptivity, doing precision modeling. And of course, why should we not? We've got such advanced technology. We can even make, the best embryos to even synthesize gametes with IV gametogenesis. But then, dear friends, I think all of us should know our limitations, especially not just as general gynae and as fertility specialists, that while these are going to stay, are we going to make all of the mothers that come to us or all the women pregnant? Certainly not. And that's the message that should go from all of us, be it the fertility specialists or general gynae, because this is the data which comes from HFEA, one of the most robust, kind of registry, which says that over the years, the trends from 1993 haven't really crossed 50%. So you look at it, the 34, the lesser than 34 are the ones which make to an IVF live birth rates of that's pregnancy rate per fresh transfers of 40%. Maybe with frozen, we'd be a little better to 50, 55, but certainly not 100. And that's the message that would go. So just end my talk here. This infertility is on the rise in India. I think it's far more important for us as general gynacs to, or whatever healthcare workers we are, not just gynacs, but in whatever roles we play as even GPs, to counsel our women and of course men on the declining, reserves. There is a window of opportunity to all of us, and we should utilize this best by making an investigation protocols which are not just driven by evidence, but they're cost effective and they're less time consuming. And of course, would stress that not to add too much of layers in the recipe of giving them a baby, because this could be more harmful than helpful. Timely referrals are important, and I think to end, I think ethical practice is the way forward for all of us. And I'll just end here to say that we have a very good public funded facility, which is not just research, which is being supported very generously by the Infosys Fund, and we take pride in saying that we are one of the best labs in the Northern India. Thank you very much.
What would the gynecologist look at while choosing an IVF center?
IVF setup.
Yeah, I mean, where to send the patients to?
Well, I think that's a very political question, and I won't say that because I said, and I think it's very difficult for me to answer, because in a country where you're driven by a lot of incentives, and I'll be very candid about it, people may not like me, how ethical we are. I won't say that I'll be driven by a lab which says I give 85% success. That's what I get to hear sitting in an OPD where I see on an average 700 to 750 patients in outpatients, where the wait lists for IVF in a public funded are large. I don't get surprised, and I kind of would get irritated in my younger years, but today I smile when they say, Doc, you just said 35 to 40 at my age. The IVF center just across your hospital says 85. Earlier I would say, go to them. Now I just smile because I still know that whatever her kind of profile, the sedan will never give 85% IVF. So I won't say a general gynae would be kind of driven because as of now, unlike the HFEA, unlike the Nordic registries, we do not have a registry which says who's producing what and what are our denominators. That's very important. I think the denominators are far more important, i.e., how many babies that they produce is not the issue. How many babies they got out of the embryo transfers, i.e., I'll just simply say you read the SART database and you read the SART database, which clearly tells you they got you 58% live birth rates from a PGTA cycle. But mind you, how many actually ran the race? How many actually went? If I discarded and put that table off and said how many IVF babies we made out of the women who went for a cycle, I think that's more important. And to me, referring to them is the way I would look at to advise all the general gynae. I hope I've answered your questions.
If there are no further questions, thank you, Dr. Neena ma'am. It is always a pleasure and privilege to listen to you and learn from you. Thank you so much.